Alright, we're live.
Okay. Hi, welcome to Alvernia Live Chat. We are live across Instagram, Facebook, and TikTok. I'm Dr. Tony Tan, and I'm an obstetrician and gynecologist with special interest in high-risk pregnancies. And I'm really glad you have taken time out during lunch to join this conversation. Today, I'll be sharing and answering your questions on high-risk pregnancies. Leave any questions you have in the chat group, and I will do my best to get it out to you today. Let's start with some questions we have received over the past few weeks. So Devlin Ko asks, is age the only factor that makes pregnancy high risk? Hai Su asks, I heard that if you are above 30 and you get pregnant, the baby won't be as healthy and will have implications. Is it true? So let's talk about age. Well, age is not the only factor that makes a pregnancy high risk, but it's one of the easiest to identify. A lot of people use 35 as a cutoff. There's no magic reason why 35 makes you high risk and 34 makes you not high risk. It's just that as the age increases, the mother's age increases, many risks increases. Number one, the risk of miscarriage increases. Risk of miscarriage when you are in your early 20s could be about the region of about 10%. By the time you get to about 35, it's about 15-20%. And by the time you are 40, 45, you can reach even as high as 90%. That's one. Yeah. Second is the risk of chromosomal abnormalities increases with mummy's age. As mummy's age increases, the risk of having a Down syndrome baby increases. At about the age of 35, the risk is about 1 in 300. At about age of 20, the risk could be 1 in 1,000. By the time you get to 1 in 40, by the time you're 40 years old, the risk is about 1%. And of course, when you're 45, the risk increases. So chromosomal abnormalities, miscarriages. Actually, miscarriages, the increase in miscarriages is also due to other kind of chromosomal abnormalities. So as age increases, chromosomal abnormalities increases, chance of having a baby with chromosomal abnormality increases, chance of the chromosomal abnormality resulting in a miscarriage, of course, increases. We also find that the risk of stillbirth at term, stillbirth happening at 37, 38, 39 weeks, increases when mommy is older as well. And it's a lot of people don't know this, but towards the end of pregnancy, the placenta starts to age, and as the placenta starts to age, the odds of having a stillbirth increases. The older mommy is, the faster the rate of placenta deterioration in some of these pregnancies, and therefore we are now finding that for older mummies, we like to deliver them at about 39 weeks rather than let them go beyond 40 or 41 weeks. So age is one of the factors. I think Hai Su was saying above 30, the baby won't be as healthy. That's not true. Of course, as age increases, the risk does increase, but it doesn't mean that if you're above 30, your baby, there's no chance that your baby will have will be normal. I've just delivered a 48-year-old, and the baby was well, mommy was well, it was all good. Yeah. So yes, but if you have a chance, don't wait until you're 48. Try and get pregnant when you are in your 20s. Yeah. Okay, so we're done with the age question. If you have any other questions, do come in. We'll go on and do the rest of the questions. It's Cha-Cha-Cha asked, I heard that IVF pregnancies are high risk. Is that true? They seem to be more common nowadays, and if they are specially selected, wouldn't it be more stable? Okay, so it's true, IVF pregnancies are more high risk. I think there are two main reasons for this. The underlying problem that does not allow couples to get pregnant easily probably increases the risk of the pregnancy when they eventually do get pregnant. Because with IVF, sometimes without IVF, this couple may not have gotten pregnant, but with IVF, this couple gets pregnant despite the underlying issues. And therefore, the underlying issue, sometimes it's genetic, sometimes it is the abnormalities in the uterus, they get overcome, but therefore they are now in an environment where risk now increases. That's one. Two is, of course, there's a lot of hormones that are used in IVF, a lot of progesterones, a lot of hormones that are given during pregnancy. And it has been found that pregnancies, the babies that are born via IVF, they do have a slightly higher odds of having abnormalities compared to non-IVF pregnancies. Or the risk is not way higher. For example, a normal non-IVF pregnancy, the odds of having an abnormal baby is about 2%. In IVF pregnancies, it could be about 3 to 4%. So slightly higher, not a lot higher. So appropriate screening will allow us to pick up some of these abnormalities. Thirdly, I guess IVF pregnancies tend to be in older mummies, because it's older mummies that tend to have more difficulty in getting pregnant, and therefore again age here now plays a role. I think one of the question, it says, if they are specially selected, wouldn't it be more stable? Well, it depends on what you mean by specially selected, because a lot of, in Singapore at least, it's not common to check the embryos to see if they are chromosomally normal or abnormal before they are put in. Therefore, the selection of the embryos are based on what they look like on the microscope. And if they look normal on microscope, the assumption is that they are healthy. That's not always true. A normal looking embryo sometimes may not be chromosomally normal. In a lot of other countries where chromosomal testing is more liberal, they are now able to check the embryos for chromosomal abnormalities and not put in the ones that are abnormal, and only put in the ones that are normal. So that is some truth, that you can select out some of the embryos with chromosomal abnormalities, but still it doesn't allow us to pick up every abnormality, because there are a lot of genetic abnormalities that testing for chromosomes still do not pick up. There are a lot of other environmental conditions that you still cannot screen out some of these conditions. Now, miscarriage is a common topic. Carefree now says, if someone has a miscarriage 3 months ago, how long should she wait before trying to conceive again? What can she do now to prepare her body for pregnancy? Well, two things. One is a lot of people, when they have a miscarriage, let's deal with the not so obvious thing first. A lot of people, when they have a miscarriage, whether it's themselves or friends or relatives, they will be given sometimes unwarranted advice, like, oh, I told you shouldn't be working so hard, I told you should be resting more, I told you shouldn't be drinking Coke, I told you shouldn't be doing this and that, So whether intentional or not, a lot of this unwarranted advice sometimes instill a sense of great guilt amongst parents, or amongst the mom especially, that she didn't do right to care for the last pregnancy. Now, if you understand why miscarriages happen, you will not have this guilt feeling. A lot of miscarriages, up to 70% of miscarriages, if you actually check the chromosomes of the miscarriage, the chromosomes of the fetus are abnormal. So what it means is that right from conception, these embryos were not meant to survive beyond a certain stage. And therefore, if you understand this biological fact, the majority of miscarriages are actually not preventable. And it's actually through no fault of mommy, nothing that mommy has done. A lot of parents come and say, oh, we had a big fight that day. Is it that fight that caused the miscarriage? I fell on my bum that day. Is it because of the fall that I had a miscarriage? So if you understand the biology, you will not feel the guilt. And I think if you still have lingering questions about whatever you have done or not have done that may have caused a miscarriage, it's good to discuss this with your obstetrician or gynecologist because I think it's very, very important to not have this guilt moving forward to the next pregnancy. That's one, right? Two, is the body physically ready to get pregnant soon after a miscarriage? Should I wait 3 months or should I wait 6 months after a miscarriage to try for another pregnancy? Now, the evidence is quite clear. We look at people who had miscarriages before, then we look at people who got pregnant less than 3 months after a miscarriage, and those people who got pregnant more than 3 months after a miscarriage. We found that the risk of the next one having a miscarriage was the same, whether you wait 3 months or you not wait that 3 months. So physically, the body is ready after your next period, right? So you don't really have to wait so long. It may make sense for you to wait long if you're still grieving over your last pregnancy. So really the wait for me is more if you need more time to recover emotionally more than for your physical recovery. The body is amazing, it just recovers very quickly. You're ready to get pregnant at the next cycle, right? And in fact, if you're older, you don't really want to wait 3 months or 6 months before you try again, because that again makes you older. And as you know, every 6 months, every year that you delay your pregnancy, your risk slowly increases. Yeah. So for those of you who have just joined us, welcome to Alvernia Live Chats. I'm Dr. Tony Tan and I'm an obstetrician and gynecologist practicing in Mount Alvernia Hospital, and I will be sharing and answering your questions on high-risk pregnancies. Leave any questions you have in the chat function and I'll do my best to get to it today. Okay, let's do the next question. Lily asked, I had a miscarriage last year with quite a bit of bleeding and I'm 39 years old now. Would that make my next pregnancy high risk, or is there something I should be worried about? Well, at age of 39, that increases your risk. If you had one miscarriage before, at 39, your odds of the next one miscarrying is about 20%. Having said that, if we don't concentrate on this 20%, we can always concentrate on the 80% chance that your next pregnancy will not be a miscarriage. Is there anything you can do? Well, in terms of age, you can't do anything, right? The only thing is to not delay your next pregnancy too long. Take folic acid. Take about 400 microgram of folic acid as a supplement. That will reduce your chance of having babies with abnormal spines and brain. In the past, a lot of us were giving folic acid 5 milligrams. 5 milligrams is 5,000 microgram. I've moved away from giving the 5 milligrams folic acid because there was some recent data that suggests that folic acid more than 1 milligram may increase the risk of autism in the baby. Then check your BMI. If your BMI is high, right? If your BMI is between 18 to 23, you are good. But if your BMI is high, we do find that if you bring down your BMI, we can actually reduce the next one, the next pregnancy having a miscarriage, because BMI increases your miscarriage. Other than that, at 39, you're older. Some people may have pre-existing high blood pressure, existing diabetes, or pre-existing medical issues. If you have those issues, do have a checkup, do control those medical problems, and once you control them, you can reduce the odds of the next pregnancy having a miscarriage. But there are very, very few things that you can do to reduce a miscarriage, because most miscarriages are, as we have said, random chromosomal abnormalities. So it's hard to reduce that. There are only a few things where it is due to medical issues that we can try and control to try and reduce that risk for the next pregnancy. Now, given Baby Cola says, given history of miscarriage for some women, are there specific tests you recommend to investigate possible underlying causes such as hormonal imbalances, genetic factors and autoimmune conditions? Yes, there is. So it depends on the number of miscarriages you've had so far and the timing of the miscarriages. A lot of miscarriages at 6-7 weeks are chromosomal in nature. The ones that we are really worried about are the ones that happen late. Those that happen after 10 weeks, especially those that happen at 16 weeks, 20 weeks. Those kind of miscarriages are not common. The common ones are those that happen at first 6 to 7 weeks. The uncommon ones are those that happen after 10 weeks. Now, if you had late miscarriages or you had more than 2 or more miscarriages, then yes, we often embark on testing for different set of conditions that may increase the risk of a miscarriage recurring again. Now, there are so many tests. Now, if you start doing all the tests that are in the books, in the textbooks, you will first of all spend a lot of money to not get a lot of useful data. It's more important to know exactly what kind of miscarriages they were, and then we can target the kind of tests available. I tend to divide the reasons for recurrent miscarriages into 2 groups. One group is for those that we consider treatable conditions. The other group, we consider that yes, we can find out the cause, but the treatment is controversial or the treatment is not well accepted. I tend not to do that group of tests. I tend to test for those that are potentially treatable. Now, what are these potentially treatable conditions? Now, if you have pre-existing diabetes or thyroid disease, then it's quite easy. We just stabilize the conditions. It can reduce your risk. So a test to check for diabetes, a check to test for thyroid conditions. I tend to look for antiphospholipid syndrome. Now, this is a condition where it's an autoimmune condition where you are not born with these antibodies, but you develop these antibodies during adulthood, and these antibodies sometimes cross the placenta and it can attack the pregnancy tissues, and it may result in recurrent miscarriages. Now, why do we check for this group? It's a check of 5 kinds of antibodies, and we check for this because in the next pregnancy you can take aspirin. You can also take an injection that thins the blood, and this has been shown to reduce the chance of the next pregnancy miscarrying. So that's the 3rd group of conditions. Sometimes I will check both parents' chromosomes, and sometimes both parents are normal, but their chromosomes actually show a rearrangement of a chromosome, which causes them to keep having pregnancies where the babies have unbalanced kind of chromosomal arrangements, in which case then it may increase their odds of miscarriages from 25-50% onwards. So in that scenario, that's no real treatment, but you can then do IVF. You get the embryos, you can check the embryos to see if these embryos have got those chromosomal abnormalities, and if they have, you don't put them in the next pregnancy, right? So that's some of the conditions that you can test for. Yeah. Any more questions from the audience? Okay, let's move on. Space Hin asks, what's the best pre-eclampsia ladies can do before or after birth? Well, I think the question means that a mummy may have had a pre-eclampsia in this current pregnancy. What's the chance of reducing pre-eclampsia in the next pregnancy? Now, pre-eclampsia is a condition where you are alright during the pregnancy, but around the 3rd trimester, you start to have high blood pressure, and then you start to have proteins in the urine. So that already involves 2 systems in the body, the circulatory system, and it involves the kidneys, right? Now, preeclampsia is a scary condition because it is a pregnancy-induced condition. Often resulting from placenta hormonal changes, and it can result in multi-systemic involvement, and it is a progressive disease that only stops after delivery. So it starts with the high blood pressure, it starts with the proteins in the urine, and if allowed to carry on, it sometimes involves the liver, involves the brain, you get headache, sometimes you get a fit, sometimes you get bleeding disorders, and it can make mommy very, very sick. So the easy treatment is we deliver. Once we deliver, mommy doesn't get so sick. Now, easier said than done. What if you have preeclampsia? If you get preeclampsia at 37 or 38 weeks, easy. We just deliver you as soon as we diagnose it, because baby is already mature. But what if you get preeclampsia at 28 weeks? Now, if at 28 weeks, if we have to deliver the baby is very premature. Yes, we get mommy better, but we get a very premature baby. So in some of these cases, we may be forced to actually keep the baby in there and continue monitoring the mommy, and until the evidence is such that the preeclampsia is worsening to a point where you're no longer reassured enough to continue on the pregnancy, then you deliver. That means we still deliver a premature baby, hopefully a less premature baby than the one we had at diagnosis. Now, if you had such a premature preeclampsia in your first pregnancy, there are two things you can do to reduce the risk of preeclampsia. Well, three things. One thing is you can take low dose aspirin, 150 milligrams at night in your next pregnancy. 150 milligrams of aspirin reduces the risk of you getting preeclampsia by 70% in your next pregnancy. Second thing you can do is take calcium supplements of at least 1.5 to 2 grams a day. That reduces the risk of preeclampsia by about 50%. Now, the third thing you can do is you can get a blood pressure set at home. You monitor your blood pressure at home 3-4 times a day from 24-28 weeks onwards, and look to see when the blood pressure starts to climb. And a blood pressure reading of more than 140 for the top reading and more than 90 for the bottom reading defines you as having high blood pressure. Because if you can monitor your own blood pressure at home daily, a few times a day, you are going to pick up high blood pressure way faster than you can pick up at the clinic. Because at the clinic, you see the doctor every 2 weeks, every 1 week, every 4 weeks. And by the time you pick up, you probably have this high blood pressure for a while, right? Yeah. So if you do these three things, you can reduce the risk for the next one being having preeclampsia. Yeah. Question from Facebook. Hi, Dr. Tan, I'm in my early 40s. Are there any extra tests or checkups I should expect given my age? And after delivery, what should I be aware of in terms of risk or complications because of the high-risk pregnancy? Okay, let's deal with the extra tests or checkups. Well, in the early 40s, you're worried about higher risk of miscarriage. So you also worry about chromosomal abnormalities. Now you can actually ask to have, depending on your beliefs, some would choose to have some form of screening for chromosomal abnormalities. Some would choose to have a diagnostic test for chromosomal abnormalities. By screening test, I'm talking about, I think you would know, non-invasive prenatal test. You can do a non-invasive prenatal test, a blood test that analyzes the baby's DNA floating in mommy's blood as early as 10 weeks. And that is a very good test to check for Down syndrome, trisomy 18, trisomy 13, Turner syndrome, as well as triploidy, the common chromosomal abnormalities that we see during pregnancy. That's a very good and a reassuring test. It is good for the common tests, common chromosomes, but it doesn't test for the atypical chromosome abnormalities. Some mummies may want to have a diagnostic test. That means a sure test where you can pick up not just the common ones, but also the atypical chromosome abnormalities. Now, some would opt to have a CVS, a chorionic villus sampling, at about 10 weeks onwards. Some would opt to have an amniocentesis at 16 weeks onwards. these tests will allow us to pick up chromosomal abnormalities. On top of that, we will be checking you more regularly. Well, if you don't have any pre-existing high blood pressure or diabetes, you are just at a slightly higher risk based on age. So you're at a higher risk of preeclampsia, you're at a higher risk of gestational diabetes. At 28 weeks, we will test you for gestational diabetes, and we will do a scan at 12 weeks that will predict your risk of preeclampsia. So this is a multi-level test where we check your blood pressure, we check your blood test for placenta growth factor, we check your blood, we check a scan the uterine artery resistance, and we are able to calculate for you your risk for preeclampsia. Now, if your risk is high, we will start you on aspirin, low dose aspirin and calcium as early as 12 weeks, and that will reduce your risk of preeclampsia. Now, pregnancy itself uncovers, it's a stressful period. So there are people who get preeclampsia during pregnancy or gestational diabetes during pregnancy. Now, if you get this during pregnancy, after delivery, you will recover. But what it means is that when you are stressed, your body reacts by having high blood pressure, your body reacts by having diabetes. Now, pregnancy uncovers quite a lot of conditions that you are genetically prone to get when you grow older. For example, people with gestational diabetes, 25 to 50% of them will get diabetes by the time they are 50s or 60s. If you get preeclampsia, 25 to 50% will have high blood pressure when they are older. So if we've uncovered this complications in you during your pregnancy, then after pregnancy, we want to monitor you yearly to check to see if you have high blood pressure or diabetes. Now, high blood pressure, it's a problem when you grow older. It is a problem that increases when you have when your BMI goes up, or if you start to take more salt, or you don't exercise regularly, you don't reduce your weight, then these are things that increases your risk for high blood pressure. So if you want to reduce high blood pressure when you're older, keep your weight down, exercise regularly, have enough rest, don't take so much salt in your diet. Similarly for diabetes, if you don't want to get diabetes when you're older, exercise more, keep your weight down, don't take so much calories in your diet, don't take all this bubble tea and stuff, right? And if you have a good healthy diet, you may be able to reduce your chance of having high blood pressure or diabetes when you grow older. Even if you don't manage to reduce your risk, you would clearly be able to delay the onset of these conditions, and that will make you healthier as well. So we are going to end soon. We have a few minutes left to our time today. I can take 1 to 2 more questions, so feel free to leave your comments. Yeah. Okay, I have a question from Dreamy Shen-zi. If bed rest is advised and I stay in bed throughout first trimester, will my pregnancy be safe? Now, I think bed rest, unfortunately, is one of those over-prescribed treatment that has no evidence that it works. Yeah. So a lot of obstetricians, when we run out of things to do for your pregnancy, we just say, oh, you should rest more. Yeah. In theory, resting is good, but in practice, you cannot be lying in bed 24/7, right? And in fact, if you do, it's bad, because if you're lying in bed 24/7, you're not moving, you're pregnant, your chance of clotting actually increases. The chance of clotting in the leg veins increases, and therefore you don't want to develop complications like deep vein thrombosis, especially in the calves, because if you do develop deep vein thrombosis in the calves, if these clots break, they can travel to the lungs, and it can be quite a serious condition for you. So bed rest, unfortunately, is not a good intervention. Now, of course, a lot of times, if you have bleeding during pregnancy, a lot of us will say, or you should rest a bit more. I don't think it means you have to lie in bed all day long. It just means you don't want to do anything strenuous, right? And for a lot of this bleeding during pregnancy in the early trimester is due to bleeding at the edge of the placenta, and it will, whether you rest or not, it will just stop on its own after a while. Last question from Viv Eileen. What kind of supplements would I recommend if I'm 40 and trying for my second child? Okay, I think in general, you should just take folic acid, 400 microgram, because it reduces folic acid. It reduces spina bifida. Any other supplements really depends on your individual self. If you are deficient in certain things, of course you have to take it, right? Now it depends. Women are often deficient in iron, especially women who have regular heavy periods. Because men, you don't find men having iron deficiency. If you find men having iron deficiency, we better check for colon cancer or something, But for women, it's so common to have iron deficiency because women tend to have periods. And a lot of women who have periods and have iron deficiency, they say, but my periods are not heavy. But I think it's because they are so used to having this kind of normal periods that they don't think the periods are heavy. Now, if the periods are heavy enough to cause iron deficiency, then there's reason for us to try and cut down on the bleeding. You can always give medication to reduce the flow, the heavy flow during periods. And then we can give iron supplements. So it's quite easy. You can do a blood test. We can check you for ferritin level. We can check you for hemoglobin. Now, if you are iron deficient, yes, please take iron. We don't want to blindly give iron because iron is not pleasant to take. It can cause nausea. It can cause constipation. A lot of women are vitamin D deficient as well. Why vitamin D deficient? Because a lot of women don't like to go into the sun, right? So if you're not in the sun, you don't get your vitamin D synthesized. There's very little in the food to bring up your vitamin D. So if you're vitamin D deficient, you may want to consider taking vitamin D supplements. Now, all the other supplements, I normally don't give during the first trimester because a lot of the supplements that we give during the first trimester of pregnancy actually cause nausea. And already you're going to have your morning sickness. It probably doesn't make sense to make your morning sickness worse by taking supplements. I'd rather, if you don't take the supplements and you can eat well, I'd rather you eat well. So I think we've got time for these questions. Thank you everybody for joining us today. I had a lot of fun answering all your questions. In case you miss any segment, we will also share some cut downs of the videos on our social media. If you have any specific questions or need specialized advice, feel free to reach out to us at Mount Alvernia Hospital. Look out for the next live details on our social media. Follow us on our social Facebook, Instagram, TikTok to stay informed. See you again. Stay smiling. We will end here. Thank you.